Troy Greer has served as Chief Executive Officer for Boone Health since August of 2020, where he leads the organization in meeting the diverse healthcare needs of a 26-county service area. Prior to joining the Boone team, Troy was the CEO of Loveless Medical Center in Albuquerque, New Mexico, a 318-bed, two-hospital campus, which includes New Mexico Center. Troy joined Boone Health as part of its transition from a decades-long lease with BJC Healthcare in St. Louis to operating as an independent community healthcare organization with a 392-bed hospital and multiple outpatient clinics and services throughout mid-Missouri, including primary care, home care, physical therapy, and laboratory and imaging services. The opportunity to be part of such an exciting transition spurred Troy's initial interest. As he learned more about the incredible teamwork, quality, and services, he was sure it was an opportunity he couldn't pass up. He notes, "I believe in Boone." Troy says it is an honor to be part of an organization with so many accolades, and he listens to those who have been so diligent to make Boone a success. He says it's crucial to protect the culture of exceptional quality, service, and dedication to our community and fellow team members. Troy was born in South Ruislip in the United Kingdom, where his father was stationed with the U.S. Army, but he calls Huntsville, Alabama, his hometown. Troy received his Bachelor's of Science in Healthcare Management from the University of Alabama and an MBA and Master of Science in Health Administration from the University of Alabama at Birmingham. Troy and Mandy, his wife of 25 years, have two adult children. 22-year-old Caldwell is currently completing his Army basic training at Fort Benning, Georgia, and 21-year-old Victoria is a senior at the University of Alabama. Welcome, Troy. You have the floor.
Thank you. I was muted and I realized apparently I'm not going to work very well unless I unmute. And it's funny how as soon as you write those things, the world changes around you. My daughter is now a graduate from the University of Alabama and a student at the University of Missouri, where she's completing some advanced studies in microbiology in order to go to PA school. She's also going to Moberly Area Community College to get her EMT certifications because she wants to get her 2,000 hours serving the community working in our EMS system. And so pretty proud of her. My son has graduated from basic training and is stationed in Germany. But over the weekend, all he could text us was wheels up, and we know what that means. I think he's in Ramstein Air Force Base helping the refugees coming from Afghanistan, which, believe me, of all the assignments he could be getting right now being in the infantry, I'm really happy with that one as a parent. We'd much rather him be greeting people who need help than going where some of the hostility is. And certainly my thoughts and prayers are with the 13 service member families who suffered the loss that they did yesterday. Thank you guys very much for having me. If you don't mind, I'll share some slides in a moment, but I will tell you, I didn't prepare a ton. I have 4 slides that will guide discussion, but this is a discussion. I like to have questions and talk about things. This is your institution that I have the privilege of shepherding for a period of time. But this is our community organization and asset. And so I want to make sure that we have that opportunity. So please, if I'm going quick, raise your hand, hold up a finger. As long as it's the right finger, I'll be okay with that. But just let me know that you want to ask a question. I'll be sure to pause. I was going to start off real quickly, if you guys don't mind me taking the screen. I don't know that I'll be able to do that.
Just a minute, Troy. I'm going to make you host.
Okay.
And while you are host, if someone comes in late, you need to admit them as well.
Well, it depends on whether I like them. I'm just kidding.
Okay. That's up to you.
Actually, I think I've got a green share screen. I might be able to do it without being the host. Let me try that. Okay. It's disabled. You're right. I'll wait until you do that.
Okay.
Thank you.
I can't find your name.
And Pam, if it's a problem, I can go through it without necessarily having.
No,
to do
that's okay. I can't find your name. And it was right here.
This is the joy of virtual meetings.
Isn't it though?
We got so excited a couple of months ago because we thought we might be moving past this and it could start meeting in public. And
There we go. You are now the host.
okay, thank you very much. I'm gonna go ahead and share my screen and just guide us through a couple of things. Let me pick the right one. Okay. I hope you guys can see the slide that has the mission statement of the hospital on it. I'm hoping that's the right one. Okay. I'm not going to hit play because sometimes it defaults to different screens. So hopefully it's big enough for you guys, but it's always important for us to start with our mission because that is the purpose of our institution. But there's a second part of this that I really like to focus on. But certainly the first part of our mission is not really that different than many healthcare organizations, and that is to improve the health of the people in the communities that we serve. But I think it's really important in today's day and time for all of us on this discussion. That second sentence is crucially important. We will accomplish that mission by making Boone Health an excellent place to work and to receive care. Guys, I want you to hear directly from me. Healthcare is in a complete and total crisis right now. We have more and more caregivers that are burned out after 19 months of being on the front lines of this pandemic. I saw an article that showed 37% of all nurses in New York said they wanted to quit within the year. This is really complicating matters as we look to a future, not only for the pandemic, because I have to think beyond the pandemic, but I just want all of us to be aware of this crisis. I speak to friends all across the country. The U.S. Labor Statistics Bureau actually gave two really important stats on where the healthcare crisis sort of is in 2020. So it's a little bit outdated now. We were 1 million nurses shy in 2020 of where we needed to be. With the continuing aging of the US population, they estimate we need 11 million nurses over the next 8 to 10 years, 11 million additional nurses. And so that's the challenge ahead of us. And it's why I focus on this idea of being an excellent place to work. I want to give people the opportunity to come to work every day and knowing that they have the tools, the resources, and the support they need to take care of patients. But with the kind of demand that we've seen, and we're averaging about 30 employees a day that are out because of COVID precautions. They've been exposed to somebody, they've tested positive, although we haven't had many test positive, but they've been exposed to people in their home, not so much at the hospital, but so we keep them out of the workforce. And so I just wanted to share that side of it. And one of the things I thought was very interesting is I was just doing some quick research on this whole idea of the workforce and why we're so short. In 2011, there were 41 million Americans over the age of 65, 2011. By 2019, 71 million Americans were over the age of 65. That is an incredible change in just basically 8 to 9 years. And that's one of the reasons we're seeing such a challenging time right now with the workforce. But I think it's important for us just to keep in mind that the backbone of any health system are those awesome, dedicated team members that come to work every day, ready to care for their community, ready to sacrifice their own family time in order to care for the community that they love. And I'm always going to start by saying Boone's mission is about that workforce first and foremost. And so I always think it's a betrayal if I don't recognize the hard work that they do. And we've also got an ambulance service here, and they're on the front lines. Our ERs on the front lines every day. And so this is always my point where I put a plug in that without trying to be political at all, if you are not vaccinated, please do for your own safety and for the well-being of your family. If your loved ones are not vaccinated, please encourage them to do so, because this is something that we can control the number of hospitalized patients. Here are two stats I will share with you. We look very similar to the rest of the country. Right now, of all of our COVID-related deaths, 99.5% of them were unvaccinated. 97% of our patients that are admitted are unvaccinated. It's not that you won't get sick with the Delta variant, but guys, it's very clear that you don't have the same degree of illness if you've been vaccinated. And so I encourage everybody to do that. This morning, we had 28 COVID patients in our institution. That's actually down a little bit. We've seen a little bit of softening here in mid-Missouri. So we're pretty excited about that. We still had about 30 of our employees out due to precautions associated with COVID. One thing that you may or may not have heard, Boone has not at this point mandated the vaccine. And I'm going to share my thoughts as to why, because I think they're very important. And there's really 4 things around this. Number one, and in this first stat, I'm very, very proud of, we're very close to 80% of our workforce is vaccinated. Now, if you look at national statistics, it's closer to 67%. So we trust our employees here. We've got a good team and I believe in them. And so I want to work with them to try to close that gap even further. We're doing incentives right now. We're giving huge encouragements for our staff to get vaccinated. So the first thing is we trust our employees because they've been here. They're at a high rate. We continue to make progress with that. And I think it's good to lead people to a determination instead of forcing a determination. Another part of this that I think is really important to discuss is the idea that nationally, as well as within our own workforce, those that are getting vaccinated versus those who are not fall into very different demographic buckets. And so if we were to make a difficult decision and say, you know what, you're going to have to get vaccinated or we're going to let you go, right now that would create a disproportionate outcome for demographics that we're trying to actually protect as part of our institution. So what we're doing instead of mandating it, we're sitting down with them and we're asking lots of questions. Some of the staff shared with me that they would feel better if it was somebody that looked more like them, actually telling them the stories. And so we're working with them and trying to encourage them to get that. And I think eventually we could close into close to 90% vaccinated here, which I think is a huge accomplishment. So I'm going to pause there. And right now I apologize for this. I've got a little bit of a small screen. So if anybody's raising their hand or wants to ask a question, I can only see about 3 or 4 people at a time. So I'm just going to pause and listen verbally if somebody wants to ask a question about this particular aspect of COVID and our healthcare delivery system here at Boone.
Troy, this is Kathy Jensen, and I was wondering, who do you report the statistics to about that it's, I think you said 99% of persons who are not vaccinated that you're seeing in the hospital? Who do you report that statistic to?
Well, we have to report a lot of data during COVID. In fact, the good news for us is Missouri is very well developed with our hospital association. And so those are reported to the federal government. They're reported at local levels. We work very closely with the university as well as the Department of Health to report that information. And the specific stats that I cited is one, we're also seeing those stats kind of nationally. The worst I've seen, the University of Alabama, Birmingham just released a very large study. They've had 2,000 COVID patients that have come through already. And they were the lowest percentage, 88% of their patients were unvaccinated. And that's the lowest I've seen in the country, but still that's a pretty significant number. But our deaths are about 99.5% unvaccinated, and those that have been admitted are about 97% unvaccinated. And so we report those stats. Now, one thing I will share, Kathy, which I think this is important, I encourage reporting along the status of vaccinated versus not, because I want the community to make educated decisions. And I think if they heard stats like that, that's more meaningful than just raw counts of how many people are positive.
I agree. And the reason I asked the question was that I believe it was the CDC that I called trying to find out nationally who was collecting that data of who was the number of unvaccinated people who were being who were now ill with COVID. And I couldn't get a hold of anyone that could give me that information. It just may have been that the people manning their phone lines are poorly informed. But on Facebook, there's a lot of conversation about, well, they don't really know that it's unvaccinated people who are ill.
The CDC is tracking. The CDC is tracking that information for hospitalizations and deaths. They're not tracking it just for positive cases.
Correct.
But you can get information from the CDC on.
There's about, and Carl, I guess to add on to that, there's about 30 states that are reporting it by vaccinated status. We look at our data to the best of our ability, but not every state is reporting it by vaccinated status, which makes it a little bit hard to get that piece. Because remember, when we first started reporting this data, there wasn't a vaccine, there wasn't an alternative. And so a lot of our database systems were built before the vaccine was available. One study I would encourage you to do, if you just want to Google something and look at it, the Cleveland Clinic is doing a fabulous job of tracking their own employees as sort of a data set. And it's really telling what they're able to find from that in terms of infection rates and vaccinated versus unvaccinated. But anyhow, oh, let me admit somebody. I'm sorry, that popped up on a different screen. Okay, I'm gonna go ahead and move on to cover some other topics, just to talk about some things that we've done here. I was attracted to this market for a couple of reasons. I was sitting over in Albuquerque, New Mexico, and happy as I could be. Love my health system, love the area. My kids had graduated from high school there. And I came across the idea that there was this local hospital health system in Columbia, Missouri, that was breaking away from one of the big boys, BJC, which is a nationally and actually globally recognized health system, but they felt like they were not meeting their local needs. And I thought, well, that's kind of an interesting thing professionally. I was intrigued by the concept. I mentioned to my wife, who was born in St. Louis. I said, hey, what do you know about this health system in Columbia they're breaking away from? I studied it when I was in graduate school. And she was very honest and said, hey, I was really raised in Florida. I was born in St. Louis, but we moved. And she said, would you be interested in moving there? And I said, oh, no. I said, we're never leaving New Mexico. I said, we're good. We're happy here. And I said, we're not going to go. But subsequent to that, I got called by the lead recruiter, and he asked me to come out. And I came out and I visited with the board and spent some time with the staff. And I was just blown away by what Boone was trying to do. And I believed in the mission. I believed in Boone. And so I wanted to come and shepherd them into this idea of going independent. It would have been a whole lot easier, just from an efficiency perspective, to stay with BJC, but we thought we could serve the community needs better by actually becoming independent once again. And there's a new book that's come out recently, and I've not had a chance to get it. I wish I remembered the title, but it's a book about healthcare in order to be transformed has to become local once again. There's too many systems that become so large, it's hard to be responsive to local community need. I'll give you guys some fun stuff to talk about as far as that transition. We added 75 jobs to the local market that used to be over on the eastern flank of the state. That's worth more than $7 million to the local economy on an annualized basis. That's providing jobs here. That's providing tax revenue here for those people that spend that money. We've also signed approximately $2 million worth of local contracts used to be done elsewhere. So we're using our own laundry service here and those kinds of things, because 40% of someone's health outcome is actually attributed to the economy where they live. And so we want to make sure that our health mission also includes spending our dollars locally instead of elsewhere. I was going to walk you through a couple of things regarding what we've had to do, because people don't understand what it means to break away from a large health system. As you see on the screen, we had to stand up our entire network, computers, everything had to be created. Our insurance plans, we had to get all new contracts with them. And so we installed over 250 servers. We had to put in 2,450 new workstations, new computers. We had 220 software packages that we had to migrate and make sure we moved that data for. And all that had to occur while we're still taking care of 2,500 staff and physicians that needed access to all that information. And so it has gone, I'll say, relatively well, but still not where it needs to be. And in fact, we still have things we work on every day. I think we've probably got another 2 or 3 months of really difficult challenges before things will be as smooth as we would like them to be. But certainly it's not transaction free to go independent. We still have some of the things we're focusing on very carefully. We use an EHR that's called Meditech. And the staff is learning it every day, gets a little bit better, but we still want to do some things to make it much more user-friendly. If you guys remember, I mentioned at the very beginning of the outset of our conversation that our workforce, our team members, are my biggest priority. I want to make sure they have tools that are easy to use, systems that work well for them. And so we're focusing very heavily on Meditech. Our supply chain was something that was a bit of a challenge as we went independent. We had some issues with the database install. And so we had to really up our game and work on getting our database corrected so we could order supplies. We have an interesting relationship. When you buy supplies, there's not really a giant Walmart for healthcare systems. And so we use these organizations that are called healthcare purchasing groups, HPGs. And we buy our supplies through them because they have all the types of things you would expect to see in a hospital setting. And under that relationship, we can subdivide our business by working with other health systems. And we actually work with the Vanderbilt Health System out of Nashville because their purchasing power is incredible around a couple of specialty drugs and things. So we work with them, and it allows us to keep our costs lower so we can pass that on to the residents of this community. We're working on our SciImage. That's our product that actually is used for our radiology reads. And this is the scary number that I will share with you guys. This last bullet that talks about securing our network, you would be stunned. Does anybody want to take a guess? Actually, we shouldn't do that on a virtual meeting because everybody's on mute, but we receive about 1 million hits a day from people outside of the organization trying to get into our network. And we've got a very robust computer system, but this is a legitimate threat to those of us in healthcare. But all of these things had to be migrated. We had to train staff on our new payroll system. We had to train staff on how they access their new benefits. The good news for us during this process is there were a couple of examples that I thought I would share with you because they're very meaningful. We were negotiating new managed care contracts with our largest payers, and our largest payers in this particular community are things you've heard of: Anthem, Blue Cross, and United are our two largest payers, but others were involved as well. Every one of them expressed early on that they were pulling for Boone because they actually appreciate what we stand for, and that we're high quality with a lower cost. And they said, you guys are creating value for us. And so we got every single contract we had in place, plus 2 more when we went independent. And so we were able to make that transition. But I think that the comments from some of my peers on the insurance side of the equation, they were very appreciative of where Boone was going and what we were trying to achieve. So I'm going to pause right there before I jump into just some quick other things and see if there are any questions about that side of the transition.
I want to know about the nursing school. This is Pam.
Okay, absolutely. Now, there's multiple here, and we work with all of them, but I think what you're probably referencing is our great relationship with Stevens College on standing up their nursing program. Is that what you were referencing?
Yes. Perfect.
There are 23 nursing students in that cohort. We have created about $1 million lab here at the hospital that has these really, I'm impressed by them, but they're these robotic, I don't want to call them dummies because they're very smart dummies, but they basically are patients with computer simulators that allow nurses to go up to the lab. They can practice doing procedures on them. You can put into the computer different illnesses and they'll mask those traits and those characteristics, the fever, the high blood pressure, and it allows the nurses to practice there. I think we're about 18 months away from the first graduation of that cohort going through Stevens College. And so we're super, super thrilled for that. It's a great addition, but we also work with the other universities here that are producing nurses as well. I've got a tour set up for Columbia College next week to visit with their dean of nursing because we want to try to keep all of these nurses in the local area. I meet with Jonathan Curtright, the CEO over at the university's health system, and we talk about what can we do to be as nurse friendly in this community. And so, okay, I've got a raised hand, so I'm going to stop there for just a moment. I believe Carl, and I want to say Mari. I hope I said that right.
Yeah, that's Mari. I just had a question in terms of nursing, since there's this hugely increased demand for nurses. Any indications that relaxation of some of the rules to facilitate more nurses is on the way? I know that's training. That's the the best of a bad situation, but what about that?
So I look at this in terms of sort of 3 horizons. There's this very immediate horizon, and I will tell you, we are asking questions about what can be an extension of our nurses' hands. Can EMTs do vitals on the floor so that nurses can focus on other things? Can we use paramedics to do other types of things? Can we have more CRNAs and have different staffing ratios? Because we want to make sure that that burden on our nurses is not as great as it is today. So in the very immediate term, we're trying to be creative about skill sets that we can deploy in ways that we've not historically done that, and trying to be innovative. On that moderate term, what we really want to do is we want to capture as many nurses. We have 4 major nursing training programs here in mid-Missouri, and we want to try to keep all those people local to make sure we're meeting that need. In the longer term, I agree 100%. We are going to have to find ways of educating a lot more nurses, period. And when we educate them, we've got to create the kind of environment where they are well received and they enjoy the experience. My daughter, who just graduated, her 2 roommates were both nursing students. One was the top of her class, and the only job she ever wanted since she was a little girl, she wanted to be a cardiac care nurse at Piedmont Hospital over in Atlanta, and she got that job. She started in June. She called my daughter 3 weeks ago crying and said, I hate nursing and I want to quit. And so I scheduled some time with her. I spent about 30 minutes and I heard what she had to say. And what we have to do is we've got to be very sensitive to this new workforce as they're coming in. They're not trained the way that they used to be. They're trained to the BSN level, but they don't have as much practical experience. And so we want to be certain that we're giving them that great experience, which is why we invested so heavily in our training program up here. And even though we built that for Stevens College, we allow Columbia College to use it. We allow Moberly to use it because we want healthcare providers, period. We need respiratory therapists. We need nurses. This is a stat that will scare you that I saw the other day. There's a forecast now that says we're going to be 137,000 physicians shy in the US within the next 5 years of what we need. So we're working on all three of those fronts in terms of timetables to try to ensure that we have a good workforce for our healthcare and for our community. Okay, I'm going to see if I think we've addressed those. One thing people may not know about Boone is we are a very extensive system. It's not just a single hospital. I understand it's easy to point to the bricks and mortar, but to me, care delivery is not necessarily bricks and mortar. It's people, it's relationships, it's sharing of information. And so one of the things I'd like to call attention to is that we have our ambulance service. We have the region's largest home health care service as well as hospice service. And all those things are intended to extend beyond the borders. Somebody asked me the other day about building new clinics, and I said, guys, I'm more interested in building care delivery models than I am bricks and mortar. It may be that a physical plant is important to deliver care, but I want to make sure that people are receiving care. I said, well, what if our home health agency did home calls and used telemedicine to connect in some of our rural areas? And so we're going to try to be innovative to reach out and meet patients where they are and not make them come to centralized locations. With that being said, we do have a distributed network throughout the region because we do want to be as close in proximity to those patients. Only about 37% of our patients come from Boone County. That surprises a lot of people. We are a regional referral center. I think it mentioned in the bio that we serve about 26 counties. Our furthest away location is down at the lake, and we do primary care down there. And we go pretty far north and east and west. And so this shows all the different locations that we have. And we have 2 convenient care clinics. And the convenient care clinics are really designed to try to be walk-in style. So they're not quite an urgent care, but they're very cost effective for somebody who doesn't have a relationship with a primary care provider. But a lot of people don't realize that we have this kind of a footprint and that we're that involved in kind of where we are. The next thing I'd like to talk about is sort of where I envision the system going now that we've gone independent, but I want to pause here and see if there are any questions so far before I go forward, because I do want this to be interactive. Okay.
Can you hear me?
Yes, I can. I don't know who it is.
Because you're not seeing my hand.
No, I apologize. I'm not. It's not showing.
Okay.
That's the reason when you have the display up of your slides, then for many versions of Zoom, you can't see the people.
Yes, I apologize for that.
Okay.
So,
My question, how
Yes.
many of your, and this is from earlier, how many of your COVID patients are from outside of Boone County?
it matches about that same percentage that I shared earlier. It's probably slightly more in terms of the percentage, but it's still around about 30, 35, 33% of our patients that have been COVID positive have been from Boone, and the rest of them have been from outside of the area. For a period of time, if you guys remember, Springfield and kind of that southwest corner was just devastated by COVID for a period of time. And they were calling and trying to find beds for some of those patients, and they've done a remarkable job. Those two health systems down there just deserve a tremendous pat on the back. But we have seen it because then we saw the spike happen north of kind of I-70. We saw a lot of patients coming in from there, and it sort of rotates periodically as one area will be hot for about 2 to 4 weeks, then it will kind of calm down, but then the next county will pop up. But about 65 to 67% of the patients that are here on any given day for COVID or otherwise are not necessarily from Boone County.
I'm asking specifically about your COVID patients in the hospital currently.
Yeah, it looks the same way as the rest of our demographics, maybe slightly more than what you would expect to see from the normal. It's about 65 to 67%.
Since we're on COVID, can I follow up with another quick question?
Sure,
Would
absolutely.
expand about your justification for not imposing a requirement for vaccination of the staff of your hospital. I think that's the norm in the civilized parts of the country. And the Missouri healthcare system, I believe, has belatedly moved to that. I think it's an October 1 deadline before firing. What is special about Boone Center that exempts them from this expectation?
Well, I want to clarify something, and that is, you mentioned expectation, and our expectation is that our staff will be vaccinated. What we have chosen to do, rather than mandate, we've actually chosen to say, hey, we have one of the highest vaccination rates of any system in all of Missouri. We're at almost 80% already. So we're offering incentives. We're interviewing employees who have reservations and concerns about it. It's really easy in today's day and time to assume that you know why people are or are not getting the vaccine. One of the biggest drivers for us about this is the fact that if you look nationally at who's been vaccinated, there's a demographic struggle, and that is that certain minorities are much less represented on the vaccination rate compared to non-minorities. So if somebody were to say, well, we're going to go ahead and just fire people as of this date, it's going to have a disproportionate outcome. And so what we've chosen to do here at Boone, and it's not that we're special, what we've chosen to do is actually work with those pockets that have resistance to try to understand why they're afraid, why they're concerned. We provided medical advice to them. We brought in doctors to talk to them. I've gone and visited with them. We're trying our best to get people to do it out of compliance, because if we force them to do it here, I don't know that they'll go home and encourage their families to do it. We're trying to convince people of the rational thought to try to get behavior that goes beyond just, I don't want to get fired, so I'm going to get a vaccination. The other part of that is real. There are exceptions to every mandate that you have. And if you go too quickly, people will just claim a religious exemption, they'll claim a health exemption, and those things are very hard to disprove. And so we would rather work with our staff rather than just simply giving them a mandate. But again, I'm going to point out that Boone has one of the highest rates in the entire country for workforce being vaccinated.
I just saw
Okay.
paper that were different than that.
That's right, very different. Very
So
different.
They were saying that the whites were the,
Herb, you guys are not muted.
sorry.
Okay, I'm now going to show you guys kind of a glimpse into the future, and this is not necessarily real specific, but this is areas that I'm really kind of trying to focus on. I've only been here for a year, which, by the way, this is really kind of exciting because this was the day I left New Mexico, and I arrived here on the 28th. And so very close to my 1-year anniversary. My wife and I have loved being here. But there's 3 major concepts that I'm focusing on in the sort of near future, as I'll describe it. The first really is our access point. As I mentioned before, our workforce right now is so incredibly taxed by COVID, and believe it or not, even during the summer when you normally get a little bit softer, our volumes have been astronomical, and it's just wearing the workforce down. And on any given day when 30% or 30 of our employees are out, due to COVID concerns, it just makes it even more challenging. What we really want to do is we want to build an access model that's super convenient for patients. How easy it is to get into a system, how easy it is to get back. How do we get the information to your providers so they can continue to follow up with you? How do we use our traditional services in different ways to make sure that we're reaching our community? And so we want to get to the point where when it comes to the question of availability, we want Boone to be known as yes. We want to be that facility that can receive patients from outside of the area. We want to have the workforce that's prepared for it, but you can't force it. If you try to force more people into a hospital than you have workforce, all it does is break people down. They wear out. They don't want to work there. And so we've got to balance that, but we have to build into being able to do that. One of the things that we would really like to focus on is we do have a clinically integrated network here. We work very closely with COG and some other providers, Columbia Orthopedic Group, and some other providers in the community. We want to create a network of like-minded individuals. And when I say that, we want to create value. We really want to be a value organization to our community. And the payers that I mentioned earlier when I was doing contracts with them, they shared an incredible statistic with me. They said that 10 health systems in the state of Missouri consume 82% of all dollars spent. And they told me that my competitors in the region are the most expensive that they deal with. And so what they're optimistic about is that we have a different view. We were not negotiating for the highest possible rate. We want to try to be a good partner in this idea that healthcare needs to become a better value for the money that's being spent. And so if you move to that next category, we talk about quality as a strategy. Boone has really, really good quality. We are a 5-star rated hospital on a 5-point scale by Medicare. And the reason I cite that is most people know what Medicare is. You know, I can name some other organizations, but people don't know who those are. But what are we going to do to leverage that quality? What are we going to do to leverage that strategy? I asked one of the payers during our negotiation, I said, well, guys, we have this high quality. You don't pay me any more for it. Would you be interested in doing that? And one of them offered a 3% add-on if we can demonstrate exceptional quality. And so, you know, we didn't do it the first contract. They said, we'll work on that in the second contract. But more and more, we're doing direct contracting. Orscheln Industries has a direct contract with us. And Barry Orscheln told me the other day that their healthcare costs have not increased in 7 years. Now, I did tell him, I'm like, well, it's been 7 years, maybe I need a rate increase. And so, but we want to work with our local businesses to help them be, to have a workforce that's healthy, but also economically taken care of. And so that's a huge part of what we're doing. The last part that's really important, and I know this is not terribly strategic, we have to maintain operational excellence. Boone has always been known for its quality, for the way it delivers care. And so we've got to be focused on those things that waste people's time. I mentioned earlier all the new IT platforms and those kinds of things. We have a design team that meets every single Thursday to ask them, what's driving you crazy and what can I do to make your work life better? We're trying to create the kind of environment where the staff can do what they need to do for the patients and move on without all these other cumbersome things that can honestly drive people out of healthcare because it's very complicated. We have lots of reporting responsibilities and we want to live up to those, but we want to try to keep the staff as unburdened as possible. And we also want to make sure for the community that we raise our bond rating status. And I know you may think, well, why is that? You're a not-for-profit. Right now, we are just below what's considered an investment grade bond rating. And the reason this is so important is as we grow and want to secure bonds that we pay for with hospital revenues, the interest rate is obviously impacted by how well we're positioned. And so we want to make sure that we're a good asset for the community. And in order to do that, we have to hit certain performance expectations with the bond market so that we can continue to secure those funds to expand whatever it is, the hospital, a surgery center, whatever comes our way. And so that's something that we have on the radar screen, but that's kind of a quick glimpse into the future. I'm going to stop there and open it up for any and all questions that people want to ask. I'm watching the clock and I don't want to manipulate too much time, but I'll stop there and listen for questions.
Hi, can you hear me?
I can.
Yeah, okay. So I wanted to ask in the previous section, but I guess you couldn't see my hand. So you said that you went and visited people to understand why they're not taking the vaccines. So yeah, so what did you find? I mean, why the reason why they're not taking a vaccine even now?
Well, that's a very personal thing as to why people may or may not say. I heard a couple of trends. Oftentimes they just hear repeated stories from their family. And so from that perspective, I think it's just hearing from the people around you, and that sort of dictates how you feel about it. The other thing is that sometimes culturally people have heard stories from generation to generation, and so they're concerned about it. And some will say, well, get it anyway. I don't think that's the right way to treat those concerns. I think we owe it to them to engage in conversation and dialogue to help them understand that the vaccines are safe. One thing about the vaccine that is really kind of nice this go around, unlike small samples, guys, we have over 1.5 billion doses of every one. So we've got the largest sample size that we've ever done in the world's history for research on a vaccine. And it's certainly safe, and it certainly is proven to, it was better before Delta because you were really protected from even getting the illness. With Delta, you can still get ill, but you won't get as ill. And more than likely, you will not wind up in the hospital. And I know somebody can cite the one instance from here or there. I saw a headline the other day that said there was a Southwest flight attendant that actually was vaccinated and ended up passing away. That's one of almost 5 billion people worldwide that have been vaccinated now, and I'm sure there's others, but we need to focus on the statistics. And so we want to teach and educate and understand. And I'm sorry, is it Shrita? Is that how you say your name?
Srijita.
Shrita, okay. Well, but so I think what we're hearing from our workforce is personal hesitancy because of what they hear around them. And we're just trying to educate to overcome that.
Okay. And do you think the FDA approval of the Pfizer would help increase the vaccination rate in any way?
Here, this is nice because it just happened. And as I'm rounding and visiting with our staff and asking that question, it seems to be helping a little bit. You hear less hesitancy from those that were very concerned before. But to be candid, I think a lot of people probably don't understand the distinction between an emergency use authorization compared to full approval by the appropriate organizations. And I think that's probably the challenge, but I did get some feedback, a very small sample size where people said, but I feel better now that it's not under emergency use authorization.
Okay, thank you.
You're welcome. Thank you. Scholars, you guys have a question up too? Yes.
I think we actually both have questions, but I'll go first. Mine has to do with the transition in IT systems and medical records and how that has gone, and whether you're able to have full access to the records of people who were seen there within your system when it was under BJC, and also how does information exchange with the other hospitals in town work?
Okay. So here's the interesting thing. The transition was not just about moving from one IT application to another, because we had already done that before. So in our world of digital medical records, we've had a product from McKesson, we've had Epic, and now we have Meditech. And the first two were done with BJC, and as of April 1st, so going forward, everything from April 1st going forward that's been done at Boone is in the Meditech system, and those things are readily available. Those items that predate that are available, but sometimes it's very hard to pull them out because you're pulling from multiple computer systems that are not always integrated. And so we're having to pull them up by exception. We have pulled over more than 25 terabytes of data, which is a lot of data. Someone told me that takes about 40 hours to spool up and to actually unspool when you get it over here. And so we're able to access those records. It's just not as timely. And so we actually have a large crew right now trying to help us get through that quicker so providers can get to it. We can find those things, but it's just very cumbersome. More often than not, it's not under an emergent situation. Those are pretty easy to handle. It's when somebody says, hey, we need to pull 150 records for an insurance audit. And getting all those together can be a bit of a challenge. There was a second part of your question. I'm sorry, I forgot the second part of that question.
Information exchange with other healthcare providers, like the university, for example. If I'm seeing in both places, how do my records get put together?
Well, and right now our systems don't communicate as openly. Both of our records have the option of people seeing it for clinical reasons, but they don't communicate directly. One of the conversations I had with Jonathan about 3 weeks ago over at the university was, I said, Jonathan, wouldn't it be nice if, since we leave mid-Missouri, we could come up with a common EHR that people could use and go back and forth? We are not there today. So our systems, you can see into them to get certain information. You can get information from both of our systems to the other. But as far as it being an integrated model, that doesn't exist at this moment in time. But we are having conversations about what that could look like. But that could be years down the road before that would be feasible.
Yes. And I just have an additional question. It's a little bit different. This is you're a healthcare professional, and certainly in your capacity as an administrator. We've had some, and obviously vaccines are paramount here, and getting people vaccinated is paramount. But we've had quite a bit about municipal masking, and you may or may not want
records issue. Is there any sharing of records with the VA hospital?
We can share, not in an easy way, but we share information back and forth. Certainly, as the son of a retired Army colonel and a brother who's retired and a son who's currently in, I love what the VA does for our veterans, and we want to be able to share records back and forth. We can share the information, but it's very cumbersome. And one of the reasons it's being changed right now, and you probably have seen this, maybe you've seen this, the VA right now is going through the largest EHR implementation in the nation's history, and that is that they're moving to the Cerner product out of Kansas City. And so they're adapting to that, which will give them a little bit more flexibility. I even had a conversation, should we have moved to Cerner instead of Meditech, because the VA is going to be on it, the university is going to be on it. So we want to find ways of either through some kind of data interchange or having the same record that allows us to share information a little bit more readily. It's just very cumbersome to do it today, but we can share the information for care. You have second.
Look, yes, again, dealing with records only on a personal level. Do patients coming through the Boone system have access to their records?
Yes. Yes. Now, it has been challenging as of late with all the changes to get them quickly, because like we mentioned before, we have 3 IT platforms that we may have to go to any of the 3. We had a patient record the other day where we had to pull something from our current record, something from the previous Epic record, and something from the previous McKesson record. And so it required us to go through 3 unique processes to get that total picture, but we can get them. It's just a bit cumbersome.
Is there a sign up for that, for an individual to sign up to have access to his or her records?
Yes, you can get, it would not be the record as if you came and got the entire document, but you can get a digital portal to get in and actually see your information. It would just be a different format than what you would see in the entire medical record. For instance, if you ask for your entire medical record, it would include nursing notes and a lot of information that could be pretty basic, but it wouldn't, you would have lab results and everything else mixed in. We can create a digital portal access where you can get to the stuff you really need to see that's important. But unfortunately, I don't have the technical expertise to say how right now, and I apologize. I can certainly find out from my team that does it. It's amazing how often I don't know some of the detail of what happens in the building, because I've got great team members who do it every day.
Thank you.
You're welcome. Yes, I can't see what that is. I apologize. Is it Xylebe? I tried to get away without putting my glasses on.
It's Herb. It's Herb. He just
okay. Gotcha.
Unmute Herb.
I go by many names. Most cannot be repeated in polite company, however. You look hale and hearty. You've been here a few months, but you're aware that anything except the really biggest and best established hospitals, many of them are faced by fiscal challenges that I think the public does not fully comprehend. What would you like to say about the fiscal health prospects and so forth of Boone Hospital, which many of us hope will continue in fine fettle down the road?
You know, Boone is blessed in a lot of ways. Financially, there have been some challenging years a couple of years ago, more so than right now. We were doing really, really well. And then we had our April 1 transition. And we were doing well, knowing that we were paying BJC the fees that we had to pay them for some of the overhead that we were already producing ourselves. And that was close to, I won't give you the exact number, that was close to $2 million a month that was going to St. Louis for those services that we already had now kind of built here. And so with that going away, the big challenge right now is our systems and our processes, not processes, but our systems. We're still working on making sure that all the charges reconcile and those kinds of things. We really thought it would be through the end of the 3rd quarter before we'd have a good, accurate picture. Long term, I had a call with a bond rating agency the other day. We went through kind of where we were, what we were seeing. They understood the challenge that we were going through. The best thing we have going for us right now, from my perspective, Boone right now is the high quality, low cost provider. And that's what we've been asked to do as a society. Sometimes it's called the triple aim: access, high quality access and service, low cost and high quality. I think it's the recipe to be ultimately successful. Will Boone make the kind of money that the university makes? No, but I don't charge those kind of prices either. I don't have state support. In fact, I don't receive any tax subsidies at all here at Boone. And, you know, we actually have been paying the county for a long period of time. They're working with us right now because as an independent, they want to make sure they're giving us the support that we need. I'm very appreciative of that. To be an investment rated hospital for Boone, we only have to have an operating income in the neighborhood of $8 to $9 million, which on a hospital of this size, a health system of this size, that's doable. It really is doable. We don't have to do anything drastic to do it, but we have to be fiscally responsible. We have to be good stewards of a public asset, and it requires us to do some things. I will share something with you guys that I have not shared with the public. I haven't even put out an announcement yet. I won't give you the name, but I just hired my first CFO to come join Boone. Our CFO retired as part of the transition. And this is a firecracker of a woman. I worked with her back in 2012 and 13, and she is so excited to get here. And she'll help us get to the point where we can be proud not only of our quality, our service, our workforce, but the fact that this is a fiscally responsible organization. And so what I would say right now is there are some difficult times with the transition, but the trustees planned very, very well for this and had enough reserves that we have plenty of time to get those fixed without doing something that was haphazard to our mission. Okay, I had two hands at once. Scott, do you want to go first? And I'll come back to, and I don't know who gave me the finger with Carl, and is it Marie? Is that right? Okay, so Scott, can you go next?
First, Mr. Greer, I just want to tell you what a splendid job I think you are undertaking and are doing with the good help of great people like Dr. Kennett and Dr. Blunt and the many splendid associates that you have on the staff and on the hospital board. You're to be commended, and I think all of us here and across the community appreciate you and need to say so more often. It is heavy lifting and you are thriving.
Thank you.
Second, can you give us any big picture numbers like the total debt the hospital has, your projections for gross revenue for the next 3 years, your expenses, and when you expect to have a net profit, if any, within the next 3 years?
So the 3-year window is probably realistic, although I think we'll be making a net profit for a lot closer than 3 years out. In fact, I think we could be doing that by middle of next year because we're really not that far off. And so to put that into perspective, you know, if people here are financially minded, EBITDA is sort of an estimation of cash, right? Your EBITDA, earnings before interest, taxes, depreciation, and amortization. We positively cash flow. That's the good news. When you start adding overhead, and I guess people will blame me for that. It's my salary, I guess, is part of it. But they would say that, you know, when you add that in, there's a slight operating loss. Those things can be addressed and they can be fixed. Just to give you a couple of gross ideas, we do a little bit over $1 billion a year in gross revenue. That nets out to be somewhere in the neighborhood of about $330 million of net revenue. But we run through about $330 million of expenses as well. And so it's a bigger organization and enterprise than a lot of people realize. It's really a great community asset. And that can be a lot bigger. This is one of the saddest things I will tell you, but since April, we have had to turn away more than 550 patients who wanted to come here seeking care, because we just didn't have the workforce for it. And I'm not going to create an unsafe work environment. And I also don't want to overburden the staff we have here today, because if they quit because we're just dumping more and more patients on them, we're all going to be in trouble. But, you know, why does that come up in the context of a financial operation? Every patient we say no to is worth in the neighborhood of $3,700 to $4,000 a patient that comes through. And so when you talk about that responsibility, those are huge decisions to make, because it could be a material impact on where we're going. But you have to have a well-executed plan to make sure you secure your workforce, you create a great place to work, you have the staff to take care of them, and then it's easier to get them in. So I'm very optimistic about the fiscal size, especially since I secured the CFO. She's just a real fireball, and looking forward to getting her here. The most important variable is we've got to get our computer systems talking so that we know where we are. We're missing about, when I say missing, it doesn't mean that it's gone. It just means it's not following onto our claims that we submit. We're missing somewhere in the neighborhood of $8 to $10 million every single month that's not making it out the door because of issues with our computer system. But again, 5 months in, you would expect to see that, but obviously it's not sustainable over the course of years. But the trustees had the wisdom to get enough cash, knowing that this always happens when you change your EHR platform, when you change your revenue cycle and those things. So it is not atypical. It doesn't surprise me. You know, I don't sleep a whole lot, but that's okay. We've got to get those things fixed, but we're pretty close. In fact, I was told 2 days ago that by October 1st, the revenue cycle partner we have in this believes all of our EHR and all those other things will be syncing better and letting us get those things out the door. Right now, we've not been able to bill for professional services. So the doctors group, we have about 100 providers, and we've not been able to bill the home health side of things because we've actually held back from billing them until certain things are corrected. And then we'll get caught up on them. That's the other thing too. About a month and a half ago, we were sitting on $87 million in unbilled. And as of last week, I think it was about $27 million in unbilled. So it's getting better. It just takes time and it's getting closer. And sometimes it's something very small. Like we can't drop a bill if there's any errors on it. Now, you may say you get stuff that have errors on it. I don't mean errors in the traditional sense, but if the systems don't communicate and align, that bill will not go out the door because we don't want to create an error that's actually fraudulent or something like that. So it requires us to go through as many as several thousand accounts each month to make sure that the bills are accurate.
Thank you.
Thank you, and congratulations and good luck and blessings for the future.
Hey, thank you very much. I think, Hank, you had another question? Actually, there's some hands up too. I think Barbara, let's go. Go ahead. Hey.
Oh, Sue? Yeah, okay.
Sue, yes. Hi, Sue.
Okay, I just wanted to say, one of the things that attracts people to Columbia and to Boone County is having such diverse and extensive healthcare. And I wish that I'm glad that you and Jonathan Curtright are talking, and I hope that continues down the organizations too, because I think that's critical. You do have the advantage of not having to provide some of the more expensive services. You're not providing quite the same quite wide spectrum of services, but many of your people have trained at the university, and I think that the two of you working together is a plus for our community and for all of us.
Well, Sue, and I 100% agree. You know, my mission is to take care of the healthcare needs of a community. And why would I not partner with we're both not-for-profits? You know, I will say this, they do some services that we don't do, but they also receive a lot more funding than I do for doing that same work. And so they're about 29% more expensive per service than I am, because they do have that teaching responsibility. And so we want to do what we can. Jonathan and I get along very well on a personal level. They have a senior executive that has worked with me at a previous stop. He did call me when I accepted the job and asked me, "What are you doing?" I said, "I'm coming there to work with you or to compete with you. We'll see." But he's a good friend of mine that works over there. And so we want to do what's in the best interest of our community. And I think you'll see Jonathan, us, and the university and Boone really working hard. We don't know what it will look like. We've talked about doing some things together. And if you guys noticed, I hope you did, we combined our efforts for the vaccination clinics when they first came out.
Right.
We worked together on those things because we owe it to the community to get our act together and actually collaborate more. I'm going to go with Barbara next. I think your hand was up the longest, Barbara. I apologize if I missed you earlier, because I'm now able to see most of the small screens. Barbara, can you hear me? Okay, we'll come back to Barbara. Pam, I believe your hand was up.
I think the Missourian might like to know the name of the new CFO if you are ready to give it.
We have a release next week that will come out. Here's the one thing. I like her and I know her, but I want to make sure she passed her background test and her drug test.
Oh, okay.
So that's why we're holding off. She actually is readily available. She was en route to take a job in another state. I caught her at DFW and I told her, I said, "Don't get on that plane. I want you to come work for me." And she actually called them and said, "I'm not going there. I'm gonna go work for Troy." And I was like, "Very good." So, but next week we have a press release that we will give out to the community. But I just want to make sure before we do that everything is appropriate. Since we are a healthcare organization, we have to do all those background checks and things like that.
Our reporter will be waiting.
Thank you very much. Yes, Mari.
I have a question regarding the support that Boone Health has provided to community health. the
Yes.
last several years, there's been a fund that has really enabled the city county health department and the primary care clinic, the FQHC, to serve the community well. Is the plan to continue that practice?
We don't know, and I'll tell you why. The county, now that we are independent, wants to make sure that we are fiscally sound, and they're doing what they can to help us with that. Here's what I would say, not necessarily that one item, but there's several things we do that used to be the burden of the public that we've taken on. For instance, the ambulance service. It's a very important service. They're very involved. We lose a significant amount of money on the ambulance service on an annual basis, but it's not as bad as when the county ran it. And so we found ways of creating some economy of scale. Some of that workforce works in other parts of the hospital, which creates a little bit better economy of scale. And so I don't know exactly what that will look like. We're working with the county now. It's very collaborative. We want to make sure that we join them. One of the things that we have said is, well, what services aren't being met that we can help with? Because we do a lot of those same activities. As I mentioned before, we do have a significant amount of uncompensated care that happens on a monthly basis too. So we just don't have that determined quite yet what that will look like.
And have you costed out how much the hospital will gain from Medicaid expansion? Are there estimates of that?
There are estimates. I do not have it off the top of my head. It's why I hired a CFO, because it's that idea. But I will tell you that hospitals will never do very, very well with Medicaid. It's just not priced that way. But I will tell you, I left a community where 49% of the community was qualified to be on Medicaid. And so when I hear people say, well, you can't survive on that, I'm like, you better find a way, because we're going to have to really know how to do our business. And it's not the fun part of my job. I love putting together systems and programs and creating a great work environment. But the hard part of being an executive is you do have to manage all sides of that, including the financial side. So we will have to. In fact, we took on 2 insurance products this time that were around the Medicaid product that we had never participated in before. And we agreed to take those contracts this year because I said, hey, we're a new entity. We need to be serving this community. Those patients need care and we want to be available to them. But I don't have the model of what that might mean. Hopefully, in my previous experience, it's a better shift. It will obviously work out better for us than it did before, because as I mentioned before, we are losing about $900,000 a month on uncompensated care. So it has to have some positive impact, because we're going to provide the care nonetheless. So any reimbursement will help.
Pam, your hand is still up.
Oh,
Or you have another
sorry.
question?
No.
No problem.
Sorry.
Just want to see if you have another question. We're over time now, but as long as Dr. Greer still has time and you all have questions, I'm perfectly okay with continuing this. I will need to drop off here pretty quick.
I'm going to check. I had a knock earlier, but I was enjoying the conversation, and everything over here is going to be hard. So I'd rather talk to you guys. So let me just validate. I am happy to stay on. I just want to make sure.
Yeah, see if you got.
Okay, I can go a few more minutes. We have an employee celebration for one of our top performing nurses that I want to go and be a part of, but I can come in a little bit late for that. So I'll take another question or two and then go to that event. Now I've scared everybody. They feel guilty.
I'm looking for other questions too. I'm looking for hands raised. Oh, there we go. Herb has his hand raised again. As soon as he unmutes himself. Yeah. I was gonna look for the right button.
Yes, I probably did it. It's hard to get me to shut up, but anyway, it can't be done. I want to thank you very much for coming to us to tell us more about the hospital system that you're managing, more, I think, than we had from other sources. Thank you very much. And thank you for agreeing to come to Boone County.
Oh, you're very welcome.
And
Very welcome.
further, I want to thank you for what I hear is a cooperative, albeit some competition with the University of Missouri. Cartwright is a former student. I hold him in very high respect. And it sounds like we're lucky to have the two of you in the forefront here. Thank you.
You're very welcome. And I will say this, it's been an honor to come and be a part of the community. And secondly, I will go speak to any group, anytime, anywhere, because this is your facility. This is your county institution. And again, I am just a steward that gets it for a short period of time. We hit our 100-year anniversary this year. And unfortunately, it's in a COVID pandemic where you can't throw a giant party, which was our hope. But anyway, it is an honor. And I'm just grateful anytime I can share the story here, because I'm proud of our workforce. I am proud of our caregivers every day that put their neck on the line. And I just feel for them right now. And if there's anything any of you guys can do, please, please, please support our clinicians. They are beaten about the head and neck. They're tired. They see things, and something happened today that somebody said something to a patient they shouldn't have said, and they were upset. They were tired. They're working an extra shift. And everybody's like, well, we may have to fire that employee. I said, guys, try to understand the perspective they're coming from. I know it was inappropriate. They shouldn't have said it. But we are working our healthcare workers to death right now. And it's up to me and others to find solutions for that. And we've got to step up and find those solutions. So thank you guys for the support. Thank you for letting me be your guest today. Sorry if I was a little long-winded. I appreciate the questions, and I will let you guys go and go thank my nurse that won the award, if that's okay with you guys.
Thank you again for being with us this week.
Thank you all. Have a blessed week.